co-lead of the REMAP-CAP trial, a trial designed to adapt also to acute pandemic needs, such as COVID-19. She's also co-author on the Surviving Sepsis ESICM SCCM sponsored guidelines on COVID-19. Welcome, Lenny, and thank you for joining us today. Matteo Bassetti, he's the head of the Infectious Disease Clinic at the San Martino University Hospital in Genova in Italy and full professor at the University of the same city. He's involved in many different societies and actually very present in both professional and lay media when it comes to explaining what COVID-19 is and how we should manage it. Welcome, Matteo, and again, thank you for joining us today. So today we want to cover anti-infective management in COVID-19. Matteo, in fact, will kick off and focus on antiviral therapy, what works, what doesn't work, and what could maybe work in the future. And Lenny will then take on the issue of bacterial and other co-infections and superinfections and discuss diagnostic and therapeutic challenges in this field. Questions and answers will come after that. If you want to submit a question to us, you can use the chat or comment function of Facebook Live or YouTube, or whatever you're using to watch this webinar. Questions will then be put to us, and I'll try to summarize them and put them up to our excellent speakers today. So I'd like to give the word to the first speaker, Matteo Bassetti, on the use of antivirals in COVID-19. Matteo, please.
So thank you very much, Jan. Thank you for the invitation. I am really happy to participate and to collaborate again with this fantastic society. So we did a lot of work together in the past. So I'm very proud to be with you today and to share with you some of my knowledge about the management of this disease that we face in my country in the past 3 months. So let me share my screen. And okay, so my task today is to talk regarding antiviral therapy in COVID-19. So, and I will go through the different possibilities in the treatment of this kind of disease. We know very well that unfortunately we don't have a lot of weapons to fight against COVID-19, at least at the moment. But I will review the different options, the old options, the new options, and the future options for treatment of COVID-19. So these are my disclosures, but let's start with the first drug. So you remember very well that more or less 3 months ago, when we start seeing the first cases in Europe, we start using as one of the antiviral lopinavir/ritonavir. This is a very well-known drug for infectious disease specialists because this drug has been used many times in HIV patients, because this is a drug active against HIV, but it's also active against SARS-CoV-1 and also MERS-CoV in vitro in an animal study. And at least in the first phase of the disease, it has been used in off-label way for this kind of infections. At the beginning, we start using the drug without any evidence, but then the first study was published in New England Journal of Medicine by Cow, and it was a nice experience in adults hospitalized with severe COVID-19. And the primary endpoint was the clinical improvement from the randomization. It was defined as the composite of discharge from the hospital or improvement of 2 points on a 7-category ordinal scale, ranging from no need of hospitalization to death. And they include 199 patients, 99 treated with lopinavir/ritonavir and 100 with supportive care. And the primary endpoint was the clinical improvement, an odds ratio of 1.24 for lopinavir/ritonavir. And when they analyzed the 28 days mortality for lopinavir/ritonavir, was 19.2 for lopinavir/ritonavir and 25% for the standard of care. So the data were not so encouraging, particularly when we look at the time to clinical improvement in the ITT population. And you can see very well that there were no difference between patients treated with lopinavir/ritonavir and patients treated with in the control arm. And for this reason, unfortunately, the data about lopinavir/ritonavir and in general about the use of antiretroviral drugs similar for darunavir/ritonavir are not so encouraging. So I would like to cite, a few days ago, we published a position paper, a current position paper of the Italian Society of Anti-Infective Therapy, for which I am the president actually, with the Italian Society of Pulmonology, and we published this experience in clinical microbiology and infection, and we try to have some statements about the different options. And you can see that our first statement was for the lopinavir/ritonavir, and at the present time, evidence from the first published randomized clinical trial does not support off-label treatment with lopinavir/ritonavir in COVID-19 patients. These results should also discourage the use of other protease inhibitors, at least until results of dedicated randomized clinical trial are available. Actually, we are not using anymore any antiretroviral drug. So the second story is regarding remdesivir. So this is another very interesting drug, very active against SARS-CoV-2, and is also active in vitro against other coronavirus like SARS-CoV-1 and MERS-CoV, and favorable effects in animal MERS model. And during the first phase, the drug has been used in the compassionate administration. And based on that, we have a nice study published in New England Journal of Medicine. First author was Grain, in which they analyzed the compassionate use of remdesivir for patients with severe COVID-19. Many of them also treated in Italy, in China, and in other countries. They include 53 patients receiving compassionate use, and the clinical improvement was achieved in 68% of the patients. But at the conclusion of the study, that we need randomized clinical trial for efficacy. And these are the data, and you can see very well, this is the cumulative incidence of clinical improvement, was particularly favorable for patients lower than 50 years age, but also some improvement in patients between 50 and 70, lower for patients higher than 70. So, and when we look at the baseline oxygen support, you can see that these are the data for invasive and non-invasive support with a cumulative incidence of clinical improvement in the patients treated with the remdesivir. So there was some improvement, particularly obviously more in non-invasive ventilation. So then this study suggests that we need a randomized clinical trial, and the randomized clinical trial has been conducted in China. And the primary endpoint of the randomized clinical trial was clinical improvement up to day 28, defined as a composite of decline of 2 levels on a 6-point ordinal scale of clinical status, from 1 that was equal to discharge to 6 that was equal to death and discharge from the hospital. They include 237 patients, 158 in remdesivir and 79 placebo. Unfortunately, the study has been stopped before the planned number of enrolled patients, because the disease epidemic declined dramatically in China. So the result, the primary endpoint, was a clinical improvement. You can see here 1.23 for remdesivir, and the 28 days mortality was equal in remdesivir and in placebo without any difference. So, and when we look at the cumulative improvement rate, was not difference in the group treated with the remdesivir and in the control. So the trial was not favorable, but there were a lot of limits of the study. The study was interrupted before the end, and probably was underpowered for any conclusion. And the most interesting one is the one presented by Tony Fauci just a week ago, in which Tony Fauci present preliminary data that show that remdesivir has a clear-cut significant positive effect of diminishing the time of recovery. And Fauci said that the recovery time was reduced from 15 days to 11 days in the drug trial, which involved over 1,000 hospitalized patients in US, Germany, Denmark, Spain, Greece, and other countries. And this is the first truly high-powered randomized placebo-controlled trial for a coronavirus trial. So for this reason, the drug has been approved by the FDA in US just last Friday, and maybe EMA is going to review the data, and we hope that the drug will be licensed even in Europe soon. So for this reason, in our commentary, in our position paper, remdesivir should be currently used for treating COVID-19 patients only within a randomized clinical trial, preferentially, or compassionate and expanded access program owing to its investigational nature. We will see what happens in the next weeks, and I hope that even EMA will approve the drug to be used in our countries. Another option is represented by umifenovir, and the study that has been published very recently in Clinical Microbiology and Infection showed no improvement in clinical outcome. This was a retrospective study in which they include 81 patients, 41 with the umifenovir and 31 with the control group, and the median time to negativity were 18 days in the umifenovir and 16 days in the control group. Not F of third, but they include only mild case, and the ICU patients were excluded. So it's very difficult to draw any conclusion, but in my opinion, this is a drug probably not to be used. Another drug that, at least in my country, was discussed, particularly in the social media, was the favipiravir, that is an antiviral drug licensed in Japan and in some other countries. So in this study, they include 120 patients treated with the favipiravir and 120 patients receiving umifenovir, that is, the name is Arbidol, and there is a higher rate of clinical recovery for favipiravir, but all-cause mortality was 0 in my case, and paper still be peer review. So we want to see more data about this antiviral drug, but seeing 0 mortality is really questionable in terms of trial design. And our conclusions in our position paper were pending high-level supporting evidence, favipiravir and umifenovir should not be used outside randomized clinical trial, at least in those countries where they are not approved for other indications. Let's move now to other antiviral options like oseltamivir and zanamivir. They have no apparent activity of oseltamivir and zanamivir was previously observed against SARS-CoV-1 in vitro. The fact that up to 76% of the first critically ill patients with COVID-19 receive oseltamivir may also be related to the suspicion of infection or co-infection with influenza. And I think the data for these two drugs are not enough. And oseltamivir and zanamivir should be used only in the presence of a suspect proven concomitant influenza A. So this is the only reason why these two drugs can be used in treating COVID-19 patients. Then there is the second story, and the second story is the one regarding chloroquine and hydroxychloroquine. And the rationale is that for this drug, we have some antiviral activity and some also immunomodulatory effects. And there is a less toxic profile of hydroxychloroquine and more potent in vitro activity against SARS-CoV-2, and this is the reason why we are actually using hydroxychloroquine more than chloroquine. So I like to show you the data about one study that has been published on 20th of March in the International Journal of Antimicrobial Agents, in which 26 patients treated with hydroxychloroquine compared to 16 control were treated with hydroxychloroquine, and 6 patients treated hydroxychloroquine also received azithromycin. At day 6, 70% of hydroxychloroquine treated patients were virologically cured in compared with 12.5% in the control group. So there are a lot of selection bias, and baseline viral load may have biased results toward observing a favorable effect of hydroxychloroquine administration. But opposite result, apparent absence of reduction of viral clearance, were recently described by another French group, albeit in a very small sample size of 11 patients receiving hydroxychloroquine plus azithromycin. So more marked effect in patients receiving azithromycin in addition to hydroxychloroquine, but caution needed because of the very limited number of patients in the combined treatment subgroup and the possible increased risk of QT prolongation by combining the two drugs. So be careful in using this drug in combination with azithromycin. So this is another trial in which the effect of high versus low dose chloroquine diphosphate adjunctive therapy in patients with severe coronavirus was published in JAMA Network Open. The high dosage present more instances of QT interval greater than 500 milliseconds compared with the low dosage group, 450 BID on day 1 and once daily for 4 days. So for this reason, pending result of randomized clinical trial, we currently suggest the use of hydroxychloroquine for treating worsening patients with COVID-19, provide no important drug interaction, can be anticipated, and with close monitoring of hepatic, renal function, and QT prolongation. But the conclusion for the panel was that this suggestion is based on its demonstrated activity in vitro against SARS-CoV-2, although weak, and the availability of low-level clinical evidence of anticipation of viral clearance for a small controlled, non-randomized study, although it should also be kept in mind that the study was highly susceptible to bias, and there is still no data regarding our clinical endpoints such as crude mortality. So very important, for this reason, hydroxychloroquine should be preferentially administered within the framework of investigational study. I discourage to use hydroxychloroquine outside of investigational study, outside of randomized clinical trial. When this is unfeasible, off-label use may be considered according to the local protocols and consent procedures. In view of the absence of evidence, we are currently unable to support the use of hydroxychloroquine in asymptomatic or mildly symptomatic non-hospitalized patients outside investigational study. The same applies to prophylactic use. So another point that I like to discuss with you is the one regarding anti-inflammatory drug, and particularly regarding the use of tocilizumab. So we have a very good experience about tocilizumab in my country. So we treated several cases, and this is a recombinant humanized monoclonal antibody inhibiting IL-6 receptor. And the rationale is that COVID-19 patient may develop a secondary hemophagocytic lymphocytosis, an under-recognizing inflammatory syndrome characterized by a fulminant and fatal hypercytokinemia with development of IBS and multi-organ failure. So tocilizumab has been used widely in China. And this is one of the first experience published in PNAS in 2020, at the beginning of the year. And within day 5 after tocilizumab, 15 of the 20, 75% had lowered the oxygen intake, and 1 patient needed no oxygen therapy. All patients have been discharged on average 15 days after giving tocilizumab. This is the first experience. And these are the CT scan of the patient, in which you can see very well the improvement in patients treated with tocilizumab with a very important result. So in our guidelines, in our position paper, we recommend that owing the lack of high-level evidence, administration of tocilizumab in patients with COVID-19 should be preferentially occurred within the framework of randomized clinical trial. Off-label use according to local protocols and consent procedures may be considered only in those COVID-19 patients excluded from randomized clinical trial or hospitalized, where randomized clinical trials are not available, will still be implemented, and who are worsening while receiving standard supportive care in the absence of concomitant superimposed infections. In our opinion, this could be a reasonable off-label use of tocilizumab in these early phases of COVID-19 pandemic. So we have a very good experience about this drug. But in the absence of clinical study, we suggest that also other immunosuppressive and/or immunomodulatory therapies like anakinra, Janus kinase family enzyme inhibitors should be preferentially administered within randomized clinical trial. This also applies to modification of the immune response through high-dose intravenous immunoglobulin or plasma from convalescent patients, which, although promising in very small case series, both deserve dedicated randomized clinical trial investigation to clearly understand their role in impacting COVID-19 outcomes and their tolerability. So this is the very last point that I like to discuss is the use of convalescent plasma. So in my country, there are a lot of rumors, particularly in the social media and in the newspaper and in TV, about the use of convalescent plasma, with a lot of pressure from the media on doctors on evidence-based medicine. Administration of convalescent plasma containing neutralizing antibody was followed by improvement in the clinical status of 5 clinically ill patients with COVID-19 ARDS. This was the first experience from China, and this was a preliminary communication in JAMA. And these are the data, and you can see very well the days post-transfusion, and you can see the effect on the specific IgG, IgM, and then the neutralizing antibody titers. And you can see that there was an important response, at least in these 5 patients treated. And this is another paper published in PNAS by Duan, in which they show you the improvement with the convalescent plasma in these 2 patients, patient 9 and patient 10, after the convalescent plasma. And this is another brief report in Open Forum Infectious Disease about high dose intravenous immunoglobulin, and you can see the effect of the immunoglobulin that the patient received for 5 days, between day 12 and day 16. What about the steroid? There are no randomized clinical trial has been conducted on corticosteroid administrations in COVID-19, and there are controversial opinions regarding extrapolation for previous studies in SARS-CoV-1 and MERS-CoV patients. In an observational study in 84 COVID-19 patients with ARDS in China, methylprednisolone was associated with reduced progression to death. This was a very, very interesting paper about the use of steroids with a very important odds ratio protective for mortality, for progression to death. And this is the data about prednisone, and you can see very well that the patients treated with prednisone present an higher survival probability, and this study has been published in JAMA International, JAMA Internal Medicine. So based on all of this data report about the steroids, we recommend that considering that overwhelming inflammation and cytokine-related lung injuries might be responsible for rapid progressive pneumonia and clinical deterioration in COVID-19 patients, we suggest, this is an expert opinion only, to consider administration of corticosteroids in critically ill COVID-19 patients with ARDS or with worsening of non-ARDS respiratory failures in the absence of bacterial fungal superinfections, independent of the ICU admission. On the other hand, in the absence of convincing evidence, the following cannot currently be supported. Steroid administration stratify according to inflammatory markers, steroid administration in non-critically ill patients, COVID-19 patients. And the last point, and is under review for JAMA, is our experience with tocilizumab and steroid in patients with severe COVID-19 pneumonia. So we have very encouraging and new data. And these are the patients included. We include in the study 45 patients treated with methylprednisolone, 29 with tocilizumab, and 56 with combination of methylprednisolone plus tocilizumab. And you can see very well all the characteristics of the patient. And here you have all the respiratory parameters. You can see that the ratio O2 FeO2 was around 200 in the 3 categories of patients, and you can see that there were many patients with non-invasive ventilation. But the data are very interesting and really encouraging. You can see very well here the free survival, and you can see that when you combine tocilizumab plus steroid, you have better survival of the patient treated with a combination. And this is the reason why actually in my hospital we are combining, when we have high level of IL-6, steroids plus tocilizumab 2 dose. What about the actually ongoing randomized clinical trial that are registered at the clinicaltrial.gov? So we have actually 16 trials with lopinavir ritonavir. We have 7 trials with remdesivir. We have 3 trials with darunavir cobicistat, 4 with favipiravir, 3 with tenofovir, 43 with hydroxychloroquine or chloroquine, 5 with methylprednisolone, 8 with tocilizumab, and 2 with anakinra. And I really hope that we will able to see the result of all these randomized clinical trials soon in order to know how to manage this kind of infections. Last point is regarding the side effects. Don't forget that when we decide to use this drug, there are obviously some side effects. And these are particularly true for lopinavir/ritonavir. And this is the main reason why we decide not to use any more lopinavir/ritonavir in our hospital due to the very high adverse effect profile. But the same is also for hydroxychloroquine, particularly the retinopathy, but also the risk of QT prolongation, and also many other adverse effects, including Steven Johnson and abdominal pain. But similar, we have also for tocilizumab and anakinra. Be careful, because particularly with tocilizumab, there are several problems like important grade of neutropenia, and we can have also very important increase in ALT, AST, and many other super infection due to pneumocystis, mycobacterium tuberculosis, and also varicella. And these are very similar also for anakinra. So be careful in using this drug outside of the randomized clinical trial or outside some very well designated protocols. Thank you very much for your attention.
Okay, thank you very much, Mattea, for this nice overview. Clearly, I understand your message. There's a lot of potential drug candidates, not a lot of evidence though, and only a few so far have been subjected to a rigorous randomized controlled trial, but hopefully something will come out of the ongoing studies. So without further ado, I suggest we move on to the next presentation, Lenny Derde, who will cover superinfections, co-infections in these patients. Lenny, please.
Yes, thank you, Jan, for that. Thank you, Jan, for the introduction and also for your previous introduction. Welcome everyone to this webinar. I'm very happy you're all joining us. And as Jan alluded to, the title of the talk I'm supposed to give is Bacterial Infection and Antibiotic Use in COVID-19. And you may immediately think, stop right there. Talk to the hand, because antibiotics are just irrelevant in this viral disease. And you could log off. You can see your Twitter feed or do the dishes. But if you can stay for this webinar, you may agree with me in the end that managing infections in COVID-19 patients is a lot more difficult than in your regular ICU patient. The first question is, should we give empiric antibiotics to these patients? So that is assuming they immediately come into your ICU from their home. And the honest answer is we don't know. There's not a lot of data on that. If you look at the reports, especially the ones coming from China in the beginning of this pandemic, antibiotics were used in about 60 to 80% of patients. And very understandably, that percentage went up with severity of disease. That's not a formal analysis, but if you look at the numbers for severe and less severe, you can see that the more severe patients got more empiric antibiotics. And that's not completely illogical, because if we look at other viral pneumonias like influenza, we know from that infection that bacterial co-infection is very common. So it may not be such a bad idea to give antibiotics. Obviously, if you've started empiric antibiotics and your patient turns out to have COVID-19 and you have other reasons to suspect bacterial infection, co-infection is not an issue, do consider stopping it if you can, but it's not illogical to start it at the beginning of an admission. Another reason to give patients with COVID-19 empiric antibiotics could be the use of macrolides. So this does not refer to literature on COVID-19, but it refers to the CAP literature and pulmonary infections literature in general. So what's known from that literature is that there are mainly small and observational studies, I have to say, that macrolides could have an immune modulatory effect. Again, I'm a bit careful because these are only small studies and they're observational, so we can only say something about associations, not about causality, but the signal is consistent across in vitro studies, animal studies, and clinical studies. So to summarize all that literature, I think the jury is still out on whether or not macrolides can have an immune modulatory effect in pneumonia, and specifically COVID pneumonia, if it can benefit the patient. But it is something that we should probably, and this is kind of repeating the last presenter, be investigated in a large-scale clinical trial. I'm fully supportive of that. But now your problems start. Because now you know this is a COVID patient, you know he's admitted to your ICU, he's been very, very bad in the beginning, he's had muscle relaxants, he's been on pressure-controlled or volume-controlled ventilation for a long time. And you know, the patient is now in your ICU for 2 weeks, it's getting a little bit better, but then, you know, they have a fever, they have inflammation markers. And this is the key problem in COVID-19 patients. It's something we recognize because we have this challenge more often in the ICU, but it's a little bit more complicated in COVID-19, and I'll tell you why. I'm using the same picture again to say, stop thinking this is business as usual. It's not business as usual. COVID-19 is more complicated, and I'll tell you why. The differential diagnosis is larger because not only can it be a bacterial secondary infection, it could also be maybe a fungal infection. Or what if thrombosis in the lung plays a role? Or what if there's hyperinflammation? Or maybe even fibrosis of the lung? So this is to spell you the acronym of the best friend forever. So this hand is your best friend forever. It will teach you which 5 things you have to go through to see what the most likely diagnosis in your patients with, you know, suspicion of infection or inflammation is in COVID-19 in the ICU. And to start with the first one, you know, is it bacterial infection, or why would that play a role in COVID-19 patients, or why is it more difficult? I'd like to show you this picture. So this is a room in my ICU, has a pretty nice view, and it's very well organized. So this is one of the 3 units we had 2 weeks ago. So the pandemic has hit in my country, which is the Netherlands, and in my hospital, we've scaled up from 24 beds open before the pandemic to about 80 beds open when the pandemic was at its peak. And this was the 2nd location in the hospital we opened. So this is our recovery unit. And as you can see, it looks a little bit less organized than the last picture. This is a picture of our 3rd location that we opened, which is in the major incident hospital. And I know the people in the front are not wearing PPE, they're just setting up this unit, but as you can see through the glass, in the back, one of the units is already open. What this picture is meant to show you is we were also working with personnel that was absolutely fabulous. We worked with military nurses, amongst others, and military doctors, and they were fabulous. They learn very fast, they're very collaborative, but they are not trained ICU nurses. And I think these pictures show you that not COVID dependent, but kind of COVID load dependent for your ICU, you may have increased chances of bacterial infections in your patients. We haven't analyzed the data, and I hope we will come out well, but I think we may have more line infections in that period of the year than we ever had. I fear we have more pressure ulcers, the wounds can get infected more easily, just as a consequence of the organization of care under pressure. So that's what I wanted to say about the risk of bacterial infection in COVID-19 patients. So the last thing I want to say about that is, if you are thinking about a bacterial infection in your COVID-19 patient, don't just give antibiotics and then stop. Make a diagnosis. I'm sorry, Siri is interfering with my webinar. It's very important to make a diagnosis. It's not meronem responsive disease. You know, it's a pneumonia, it's a line infection, it's a wound infection, it's an abdominal infection with a certain causative agent, but please find a diagnosis for your patient. The second thing I said in my list of 5 things you have to consider in your COVID-19 patient relates to fungi. The question is, are COVID-19 patients more susceptible to fungal infections, especially of the lung? So the disease I'm talking about is invasive pulmonary aspergillosis. I'm not worried about Candida. I actually think what you should remember from this, although there can be day-long discussions on this, is Candida pneumonia does not exist. So we'll focus on invasive pulmonary aspergillosis. And the question is, can COVID-19 patients get that? Are they susceptible to that? And there are some arguments for why they could be and why you should think about it. So in influenza, there's a well-described association between getting IPA, invasive pulmonary aspergillosis, early and being admitted with influenza. So apparently influenza makes your lungs more prone to getting this fungal infection. This is also the case for young people. This is also the case for non-immune compromised patients, and it happens relatively early in the disease. I have to say that this association is something that's not found in every single country in Europe or across the globe. So what is thought is that also kind of the environmental exposure to fungi plays a role here. This is something that's found relatively frequently in the Netherlands and Belgium. Maybe that we just have a very high environmental load of fungi, but especially in those countries, and maybe also in your country, COVID-19 patients could be susceptible to fungi. So you have to think about it and you have to go look for it. The other thing is, if these patients are on your ICU for such a long time, and they are, we could postulate that they may be, kind of immune suppressed, as everybody who stays in the ICU for a couple of weeks will be. So that could also make them prone to opportunistic infections of the lung. So what you have to do to make that diagnosis is you have to be a bit of a Sherlock Holmes. And this is also more difficult in COVID-19 patients. The first reason being that we don't really like doing CT scans or BALs on these patients. We think, transporting these patients through the hospital may pose a threat to healthcare workers. We don't want the pulmonologist who may do the BAL to get infected. That's a operating procedure. We may want to avoid it. It's all true, and it's good to think about it, but it's a balance. There's also a disadvantage of not knowing the diagnosis of your patient. So if you really think that fungal infection of the lung could play a role in your patient, at least think about doing a chest CT scan. And if you then do a CT scan, think about whether or not you want to do one with contrast, so CT angiography, because you may also want to rule out thrombosis, which we will get to in a minute. The other thing you have to think about is infections don't always occur in the lungs only. So you may want to think about, do I need to scan the sinuses while we're there? Do I need to scan the abdomen? Is there a clinical suspicion of an infection there? And that is obviously looking for bacterial infections more than fungal infections. So the second thing you can do, as I said before, is you can do a BAL, but there may be reasons to want to avoid that. An alternative could be to do an endotracheal aspirate. That can be done through a closed suction system, which is not an aerosol generating procedure, or at least the aerosols are not getting out of the system. The thing you should not do on an endotracheal aspirate is a galactomannan test. There are numerous reports that these are false positive. And the reason we think that's true is because enteral feeding contains a lot of preservatives, and these contain antibiotics, and these obviously contain fungal cell wall components. So we've tested all kinds of enteral feeding in our hospital, and every single one gives high galactomannan values. So what you can do on an endotracheal aspirate is you can do cultures, you can look at it under a microscope, and you can also do PCRs for fungi, if that's available in your hospital. But please, if you do a galactomannan, make sure you do a BAL deep from the lung and not an endotracheal aspirate from the trachea. So the third thing to consider in the differential diagnosis of what's going on in terms of infectiousness in your patient is consider thrombosis. I think everybody who's listening to this webinar has seen these patients. We don't actually know what's going on here. There are reports that this may not be the same as classical pulmonary emboli, that there may be a local coagulation problem in the lung, because many of these people don't seem to have signs of DVT. So look for it. And the only way to properly look for that is bringing your patient to the CT scan together with your colleague, hopefully not without PPE, as I now see is in this picture. So there are laboratory tests that can guide you in the right direction. The one that comes to everybody's mind is D-dimers, but D-dimers are also increased, as you know, in inflammation and infection. And I'm pretty sure they will not help you in this type of patient. So if thrombosis is the differential diagnosis and it's high up on your list, then you have to exclude that by doing a CT angio. Thrombosis was not something that was reported very frequently from the first reports on the pandemic in China. If you look at those papers, they did a lot of CT scans, but the vast majority of those was without contrast. So that could explain the lack of finding of these pulmonary embolisms. So the next one on the list is something that's hard to stop. It's the hyperinflammation. So to be honest, we do not know at this point what the hyperinflammation thing is that happens in COVID-19. There is this picture that people deteriorate after about 8 or 9 days and then they get into trouble, and people have compared this to a macrophage activation syndrome or HLH, but it seems to be a little bit different. In the first reports that were trying to find out what hyperinflammation in COVID-19 was about, there was a lot of focus on IL-6, and IL-6 may very well play a role, but the levels of IL-6 that are found in COVID-19 patients are actually not that much higher than the levels found in your typical sepsis patient. They're higher than normal, but they're not absurdly high. So that definitely does not exclude a role, either upstream or downstream, for IL-6, but it could also be that something else is going on. The other thing that was striking is ferritin on the track of MAS, macrophage activation syndrome, and HLH, but there seem to be differences in the immune profile of these patients. There are also people that think that the kallikrein bradykinin system is involved in the hyperinflammation, and that this may be true early, but also later in the disease. And that system involves also the ACE receptors that play a role in the binding of this virus to pulmonary tissue. And that's a system that's also involved in hereditary angioedema. And if you look at the clinical picture of hereditary angioedema, it actually looks a lot like the early stages of COVID-19 with the dyspnea and the kind of fluids in the lungs. So I don't know if that's true, but there appears to be some form of hyperinflammation going on, where if you trigger it, it's very hard to stop. The engine of hyperinflammation keeps going. And IL-1 and IL-6 could also be involved in that system further downstream. So this is not uncommon for us, because every ARDS patient has a phenomenon that's a little bit like this. You know, something triggers ARDS. It may be bacterial pneumonia or something else. And then even if we treat the disease, the hyperinflammation engine keeps running. So that is a problem in this patient group, and I think we know very little about it. I think we're all very eager to learn about it and to find also specific medication that can stop that hyperinflammation from happening. So I'm not giving you much, because I'm giving you more of a problem than an answer. I'm just saying, consider that this can be an issue in your patient. And if you think it is, I think you have to find, you know, local solutions with your immunologist as to what treatment you will prescribe, or preferably, like Professor Bassetti said, you know, we'd like to investigate it in a randomized clinical trial. I think that's the best, by far the best option. The last one on my list of 5 was fibrosis. This is something that we also see happening across Europe and across the globe. It usually happens quite late in the disease, after 3 or 4 weeks. And it's really the end stage of this disease. And if you get there, that's not very good. it can be very difficult to diagnose. The two things that everybody will understand are typical are that you get a rise in CO2 with the same ventilator setting without much else seeming to be ongoing, and also the compliance of the lungs goes down. Tidal volumes become smaller with the same pressures. Then you may have fibrosis on your hands. It's difficult whether or not we should do a CT scan. I think that's, again, a matter of weighing pros and cons. If you are going to do the CT scan, to exclude, one or more of the other 4 things I mentioned, then you can look at the CT scan with the view of, is this fibrosis? But it's more of an excluding other diagnosis action than purely for the fibrosis, I think. There are no markers for this fibrosis apart from what you see happening to the ventilator settings and what you see happening to the CO2. There are anecdotes of high-dose steroids being beneficial in this fibrosis, doses as high as in the classic Maduri schedule used for ARDS. And there are also anecdotes of this working even 3 or 4 weeks into the disease, where in ARDS traditionally you'd want to give those steroids if you think that works a little bit earlier. So the problem with anecdote is we tend to remember the things that go well, the things we want to work. So these anecdotes may be untrue. And I think, the best option we have is trying to prevent our patients from getting to the stage where they have fibrosis. And if they get it, I think a treatment should again be tested in a well-designed, large clinical trial. So if you get to fibrosis, that's really a big problem. So to summarize, the 5 things I really want you to remember if you think about, giving antibiotics for fever in your COVID-19 is stop. It's a typical ICU patient. Consider thrombosis. You have to consider hyperinflammation. You have to consider bacterial infections and fungal infections, but you also have to consider fibrosis. And to these 5, best friends forever, I'd like to add 2 absolutely fabulous friends as a last remark, because what I've forgotten to say, and this occurs in other patients as well, is think also about viral reactivation. We don't know anything about that in COVID-19 patients, and I'm not just talking about reactivation of the COVID-19 virus, but also of herpes viruses or CMV. I think that's a field that's largely unexplored up to now. And obviously, if your patient gets a fever while they're in the ICU, something you always have to think about, and you have to take in your differential diagnosis, is drugs or medication, because that can definitely also give fever. That's what I wanted to share with you. So thank you for listening. And if you want to ask me any questions after this webinar or have any comments, please find me by email or on Twitter. Thank you very much.
Thank you very much, Lenny, for sharing your insights. Also the handy rule, different things we need to remember, need to think of when a patient presents with something that looks like an infection. There's indeed many other things that could be there. You nicely highlighted the close relation between inflammation and infections, and of course the resulting difficulties in recognizing infections and using our antibiotics appropriately. There's a lot of questions that came through social media. Very well, as both of you touched on, so many different issues. Of course, they cover many different aspects, and I'll try to summarize them a little bit. Maybe start off with some questions that actually both of you covered to some extent. There are quite a number of questions related to the use of tocilizumab, especially about the timing. Do you wait for mechanical ventilation? And of course, I realize the evidence is at this point limited, and you mentioned your own results, Matteo, that are currently under submission. But based on what you know now, is there a sweet spot in terms of timing? Do you use biomarker? Do you use IL-6, or should we be measuring this routinely with this in mind?
So this is a very difficult question to be answered, because obviously during the course of the disease, we use more with the belly than with the brain this drug, because at least in the first phase, we use the drug when the patient were sick. So then step by step, we change the use and we use more measuring the IL-6. So we start measuring the IL-6 in the beginning, but maybe we use in some cases in which the IL-6 was not available because of the worsening conditions. So in general, I believe that when it is a drug to be used in sick patients, not in stable, mild patients, because, you know, and in general was a combination of the two drugs. So methylprednisolone was our frontline drug, so that has been used in many cases in emergency room. And then the tocilizumab was used maybe the day after with 2 doses, 2 separate doses with the 8 milligram kilo day, with a maximum dose of 800 milligram to a maximum of 3 administration every 24 hours.
Okay, thank you. Steroids is also something that drew a lot of questions, and maybe Lenny, you can comment. You mentioned some indications, but how do you use it in clinical practice? You mentioned fibrosis and other situations where you can use it, but how do you use it? How do you dose it? Is it always the same dose you mentioned? How long would you continue? Would you say, okay, I'll wait for a few days, and when I don't see any effect, I discontinue? Any clinical recommendations on use of steroids?
There are a couple of things to say about that. So first of all, again, there's absolutely no evidence for any of this. What we do know is that steroids may prolong viral shedding. So that's something to consider. It's not an absolute contraindication, because it will probably tail shedding as a given. Sorry, I got interrupted. The high doses of methylprednisolone as given in the Maduri schedule, obviously, if you give such high doses of steroids, disadvantages can be that you're more prone to secondary bacterial infections, that you are more prone to fungal infections, that your wound healing is worse. And actually, all of the answers that we've been trying to give, I think, so far, stress the fact that we should probably not investigate one of these things in these patients. We should probably investigate, you know, should we give toci with or without steroids, and, you know, with which antiviral. That is a strategy, but you know that, Jan, that I really believe in, and it also prevents us, you know, all trying to get a patient into one trial. They should actually contribute to the answer to all of these questions.
Yeah, I noticed, for instance, that in the overview that Matteo gave us, it struck me that there was over 40 different studies looking at the use of hydroxychloroquine, which of course is good, but probably some of them will be underpowered, and joining forces in this is probably a better strategy. Matteo, I have another question for you. With the use of antivirals, we've seen inconsistent effects and often no effects of antivirals. Is it because of an inappropriate timing? Should we give it early rather than late? Because often when patients come to the ICU, they're in this second hyperinflammation state where maybe antivirals have a more limited role. Any comments in respect to timing of antiviral therapy?
So this is a very interesting question, because unfortunately, at least in our experience, we never use even remdesivir at the early phase, because we actually have one trial on remdesivir, the Solidarity, that is a WHO trial, but in the first 2 months, remdesivir was available only through compassionate use. And as you know, if you have to order through the compassionate way, needs time, 2, 3, 4, 5 days, because you have to contact Gilead in US, they have to approve your treatment, and they have to ship to you, and then you have to have your ethics committee approval, and then sometimes when the drug was delivered to our center, it was too late, and maybe the patient was already died or the patient was already survived. So in my opinion, at least remdesivir, for the characteristics of the drug and for the very high viral activity, probably is a drug to be used in the early phase. So that is the phase in which we have a very high viral load in our patients. So maybe to be used very similar in the way we are actually using oseltamivir. So you admit the patient to the hospital, you have a patient with suspect COVID-19, you start remdesivir even empirically. So this is my personal idea about remdesivir, because when we have used remdesivir, even in a compassionate way, we had good results, but was probably too late. Okay, so I think, you know, the viral load, the highest viral shedding in the first 7 days. So maybe this is the time in which remdesivir should be used, and this is probably the only antiviral that, in my opinion, has some future, because if we have to discuss again the topic of COVID-19 in the next 3 months, I'm pretty sure that nobody will use any more hydroxychloroquine. Nobody will use any more lopinavir ritonavir. Nobody will use any more darunavir ritonavir. Probably the only drug that remain in our armamentarium should be remdesivir, if there is a good randomized clinical trial to be proved that is a good option for an early phase.
Mentioned viral shedding. Also a question was asked about the effect of antiviral strategies, whether it's antivirals or hydroxychloroquine on viral shedding. Of course, this is an endpoint that may be not of very much interest to the patient, but it could be to the healthcare workers if we can reduce viral shedding and maybe therefore also the risk of transmission. Do you see any role of drugs for this specific purpose?
You see my answer? Zero. So we are actually analyzing the data. In our patient treated with hydroxychloroquine, we submit a paper that is under review, and we measure the viral load day 7, day 14, it was zero, the effect of hydroxychloroquine. So,
okay.
Unfortunately, we were forced at the beginning more by the public opinion to use hydroxychloroquine, because when we admit the first patients in the hospital, in the ICU, you know, it was difficult to say to the people, we don't use anything, because this was at the beginning. And one of the reasons why we use hydroxychloroquine was also for the big pressure, at least in my country, that we have from the public opinion. Now we stop using hydroxychloroquine. I really believe that the role of antivirals should be in the future very similar to oseltamivir. If you look at the activity of oseltamivir, it's not so good. I mean, if you look at the trial on oseltamivir, they reduce by few hours the fever and they reduce the symptoms. There is not the same effect as that we have with the antibiotics for bacteria, obviously. So this is one of the limits of the antiviral in general, particularly for RNA virus. So, and I really want to see more data about remdesivir, but I am optimistic about the potential future role of remdesivir.
Okay, thank you, Matteo. I have one small question to end, if I may, or Lenny, you want to comment as well?
Yeah, I was just going to say that I fully agree that if there's a use for remdesivir, in theory, it's logical to use it early. What I would like to prevent, however, is that we are going to use it like we are using oseltamivir, which is many hospitals across the globe use oseltamivir in ICU patients without there being any evidence of that being effective at that stage of the disease. So again, it's very important to investigate, you know, not only if this is a potentially effective drug, but also when you have to give it. So the stage of the disease, and COVID-19 makes that very clear that there are different stages. That's a very important question.
Okay, one final question, Lenny, but actually for both of you. I think it's very challenging to uphold the principles of antibiotic stewardship in patients with COVID-19. Any comments related to the use of biomarkers? PCT could be one. can this help us to guide antibiotic therapy, not antiviral?
Yeah, so again, I'm not quoting studies, but if I look at the cohort of patients that was admitted in our hospital in our country over the last weeks, it's just much more difficult than traditionally, because traditionally you have kind of, you suspect somebody of having a bacterial infection and you measure, I don't know, maybe leukocytes or a differential, and you measure maybe a PCT after you start antibiotics to see whether you are on the right track for the length of your course of antibiotics. If you want, you can measure CRP. But here, there are just too many things that affect all these biomarkers. So which is the best biomarker? I'm unsure. I think, you know, if you see, you know, either D-dimer or ferritin or IL-6 go down aggressively, then that's probably a good sign. But you can probably also see that, you know, by looking at the face of the patient. So I'm not sure which of the biomarkers will be helpful in predicting kind of which of the 5 to 7 things is going on with this patient in your ICU. I'm not sure, but it'll be very good if we can find that out. It's very important.
Matteo, some final comments from you on this?
So my final comment is regarding, so I fully agree with Lenny, but, you know, I think, you know, my impression is that COVID-19 reduced the level of knowledge about infectious diseases and about antimicrobial stewardship. We are back to more than 10 years ago. You know why? Because now everybody are prescribing everything without any single evidence. Everybody use carbapenems, linezolid, vancomycin, all the antibiotics together without any evidence, just because they believe the patient can have some bug. So we have to rebuild the knowledge about stewardship. You know, in 2 months, we lost 10 years. So we have to come back again together with our societies to teach the people how to use antibiotics, how to do stewardship, because with the COVID-19, we have a dramatically reduction in the knowledge about infectious disease, dramatically reduction.
Thank you, Matteo. I think this is a nice note to end on. And clearly, the SARS-CoV-2 not only affects the patient, but also the antibiotic decision system somewhere in the brain of the doctors treating those patients. I think we can end the session here. I want to thank the speakers for sharing their experience, their knowledge, and of course, thank also you, the audience, for being with us and for the interaction. If you missed part of this webinar, maybe you were a little bit late, it will become available on the Society's website very soon. And when you're there, don't forget to check out our previous webinars on COVID-19 or the COVID-19 marathon from a few weeks ago. So on behalf of ESICM, your Intensive Care Medicine Society, we thank you for your attention. Have a great weekend and be safe wherever you are. Thank you very much.